All right. I just want to start by saying welcome to everyone who's just joining us and to our Ask an Immunologist Paediatric Q&A session. My name's David. I'm the Programs Manager here at Immunity Canada, and I'm joined by Fiona, who's our Project and Volunteer Coordinator. And we'll be asking our panelists today the questions that you've submitted and questions that you'll be asking during the session. Very quickly, we've got about 17 families joining us from across Canada. And we just want to acknowledge that from coast to coast to coast, we're all guests on the ancestral territory of the Inuit, Métis, and First Nations people. Members are encouraged to consider their own position and relationship to the land where they find themselves as part of improving our own understanding of local Indigenous people and their cultures in a spirit of reconciliation. And very quickly, just a bit about us. We are Immunity Canada. We provide a strong voice for patients and their families, and we work with health professionals and others within the immunodeficiency community to help ensure everyone has access to the resources they need to thrive. I want to say a huge thank you to Dr. V. Kim and Dr. Luis Murguia Favela for joining us today. Hopefully you can both see them. And Dr. V. Kim is a clinical immunologist, allergist at the Hospital for Sick Children, Toronto. And she's also an assistant professor and director of postgraduate medical education for Paediatric Clinical Immunology and Allergy at the University of Toronto. She's also the section chair for immunology at the Canadian Society for Allergy and Clinical Immunology and chair of the SCID disease-specific working group for newborn screening Ontario. Her areas of focus include inborn areas of immunity, hematopoietic stem cell transplantation, and gene therapy for inborn areas of immunity and medical education. Dr. Favela is a clinical assistant professor at Alberta Children's Hospital and the University of Calgary, specializing in pediatric immunology and allergy. He is also a founding member and site principal investigator of the Clinical Immunology Network Canada, a cross-Canada group of clinical immunologists with the objective of generating and collaborating on clinical research and advocacy projects in the field of immunology. Welcome to both of you, and thank you so much for joining us today. Very quickly, after this introduction, we've had lots of questions submitted already from you, and then we'll answer questions from those that are submitted by the audience today before quickly wrapping things up. And you can participate. You should be able to see at the bottom of your screen something that says Q&A, so you can pop your questions in there. If you have any sort of technical issues, you can use the chat box and message Fiona or I, and we'll get to as many questions as we can that are coming in live and those that have already been submitted. And Dr. Kim and Dr. Favela have kindly said that any that we don't get to, we'll submit to them to get some answers. So hopefully we'll get to all of them. And very quickly, Immunity Canada events offer an array of presentations developed by health professionals, our members, and others who are invited to serve as presenters. The views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of Immunity Canada. Information provided at events should not substitute advice from your physician or other qualified health providers regarding your medical condition. And with that said, Fiona, have I missed anything? I think that's all good.
You're good.
Awesome. So over to question time, and we've had one question submitted, which was, if you're a parent diagnosed with PI, at what age should you test your child's immunoglobulin levels, or should testing only occur if a certain number of infections occur each year?
Dr. Murguia, do you want to go ahead, or?
You go her first, and then I'll jump in after.
Okay. Well, thank you again for having us come and be able to speak with you and answer some questions. I think, again, it may depend on the type of immunodeficiency that you are diagnosed with. Some immune deficiencies may involve antibody deficiency, but some may not. And it also depends on, kind of like the expected severity of the immunodeficiency as well. So some, for example, where we would be concerned about an early presentation, we may recommend doing some screening for your child very early on. Or sometimes, again, if the genetic condition or genetic cause is known, we might even recommend screening children for the genetic variant or mutation as well. Whereas some other ones, such as common variable immunodeficiency, where again, in a lot of cases where we might not know what the genetic etiology is, we do know that, again, there can be a very big range of ages of presentation. And so testing at a very young age when the child is well may not necessarily pick up or predict whether or not at a later age in childhood or adolescence or adulthood, if they may go on to develop an antibody deficiency. Certainly, I would suggest if your child has any symptoms of your immunodeficiency, such as unusual recurrent infections or autoimmunity or malignancy, that you should certainly speak with your physician or the child's physician with regards to your immunodeficiency and whether or not these manifestations in your child might be suggestive of an immune deficiency, and what the next steps for investigations moving forward from that perspective would be.
I fully agree. I don't have much to add. There was a very complete answer to that. It touches on all the points that I was going to discuss as well. So,
hey, thank you. I have the next question. My child was diagnosed with CVID at age 3. I'm told they will be on immunoglobulin therapy for their entire life. Is it possible they could outgrow the condition, or their immune system could wake up and work as they age?
correct. So, I mean, I would say first, sorry, B, I'm Dr.
Oh,
Kim.
go ahead. It's your turn. Sorry, I took along with the first one.
So I think, again, in the diagnosis of CVID, many of you would know, it's an evolving term that includes many different types of primary immune deficiencies that overall they give you this concept of CVID. I must say that it's unusual that an infant is diagnosed with CVID this young, and I would say that one thing I would want to ask your physician is kind of, are there any investigations that could take further into the diagnosis? Dr. Kim had mentioned around the genetic testing. Many causes of CVID at the genetics level, we don't know, but we do know a fair bit, almost 30% of the genetic causes of CVID we know. And I'm mentioning this just because that may help answer your question on whether this is something that it's something that you can outgrow. Usually, your immunologist should have taken all this time and effort and investigations to reach to that point where the immunoglobulin replacement therapy was established, and usually to get into that point is high likelihood that there's no way back. But again, if there are further testing and trying to differentiate what is a primary immune deficiency that you're dealing with, then you may have that answer of whether this is not something that we can change because it's a genetic condition, and hence the dependence on an immunoglobulin replacement therapy is there for good. Having said that, also we know how much science keeps advancing, and this may not hold true in a few decades from now, right? So that's something also to keep in consideration. But going into the therapy, there's a lot of reasoning going behind from us as immunologists get to that point where we suggest that this is an ongoing treatment.
Thank you so much. V, did you want to add anything at all, or?
Sorry, the hospital just made an announcement, so it's very loud. No, I completely agree. Like, again, in general, when a diagnosis of CVID is made, we do not expect the immune system to start improving and creating its own antibodies. And so we do expect that, again, once your immunologist has made that diagnosis, that the immune globulin replacement therapy is lifelong. But again, as Dr. Murguia mentioned, sometimes we, have advances in medicine that, in 10, 20 years, we might have different therapeutic options. But at this time, again, with antibody deficiency with CVID, we do not expect the immune system to improve.
Thank you. I just had a message from the audience. When we talk about SCID children, how long should these children be isolated after a traditional bone marrow transplant or gene therapy?
Very good question. B, go ahead.
Yeah, so generally, again, once a child has had a bone marrow transplant or gene therapy, it still takes time after the procedure for the immune system to, start to kick in as well as work well. And we also know that in many instances when children receive a bone marrow transplant, because of various possible complications, they're often on immunosuppression medications as well to prevent some of these complications. So that combination of immune suppression as well as you're waiting for your new immune system to kick in often means, again, that your child is still immunocompromised for a period of time after the bone marrow transplant. How long that is depends on the individual child. So it depends on how slowly or quickly the teen can come off the immune suppression, as well as how well the new cells are coming in. And again, that's something that we often would monitor after a bone marrow transplant or gene therapy, in terms of monitoring what the immune reconstitution is like. So how the new immune cells are growing and how well they work. And depending on those levels, we often would then gradually start to come down on some of the isolation precautions or some of the other kind of preventative measures that we would recommend to try to prevent infection. But that process, depending on the child and the circumstance, can often take months to sometimes years after bone marrow transplant or gene therapy.
Yes, certainly. Just to emphasize that is more is not necessarily a matter of time, but rather on the individual immune reconstitution, as Dr. Kim put it, and also the isolation also may start varying with depending on this, right? So I think if you're thinking about the full isolation that a patient receives when they're going through the transplant is very strict and very protective, that depending on this immune reconstitution, that may look different as the time goes by, and we may be more permissive of certain things as the months go by. So not to think that this isolation is the same for the full length of time post-transplant. It does vary as we move forward and we see the immune reconstitution kicking in. And the other thing that I wanted to mention is also dependent with all that Dr. Kim mentioned, but also complications along the way. There may be bumps on the road post-transplant that may delay things, even if we had prospected that this was going to happen in such time. Some complications post-treatment may delay things and may make us be a bit more protective of the kid that has gone through that procedure.
Thank you. I've got another question more about care and treatment. My son is 15 and has CVID. We are starting to think about college and him leaving the house. How do I get him more involved in his care And how do we start navigating accessing his treatment if he goes away to school?
That's an excellent question. I think it's and it's very. I think it shares for so many patients across the country, and I would say that one thing that you should encourage, and in terms of these teenagers go through a transition process and depending on the different clinics, we may approach it a bit differently. But I think one of the things that we do here is that we try to involve the teen early on, like probably around this time, around 15, to be more independent when they come to our appointments, to tell you about that. We ask them directly how to tell them about their story and all that. So the more comfortable the teenage is in telling the story, telling the condition, knowing the medications they're on really understanding what the condition is. Sometimes they've left throughout all their childhood, they've let all the decisions and everything to their parents, even around the actual diagnosis, and they sometimes don't actually understand what is being wrong. But then in these sessions that we take to transitioning to as they become older, it's important to know how much actually they know about what they have. It's important that they do, and that will help them going on. And then with the idea of going away and going to college, and with CVID, I'm assuming that that your son is on immunoglobulin replacement. So there are options, right? If your son is on IV treatment, there are options that can help these patients kind of move away from having treatments at a specific clinic, like the subcutaneous administration. And from subcutaneous administration, now there are a bit more options than just the weekly administrations. There's a newly approved medication that may allow you to have longer periods of time between applications, and I think that gives you tools, the teen and someone that is going away, tools to take more ownership of what of their own treatment, and so I would say it's leading to that. This patient going to college, that is very important, that period of time to prepare them, and I hope this helps.
Yeah, I agree. It's like really, I think it's a really important process again for teenagers and adolescents to be able to transition into adult care and take on, autonomy and ownership over their health. And I agree, this is a process that, should start as early as you can, even before they reach the teenage years. And again, it's depending on their developmental stage in terms of how much information, they're willing to listen to, as well as retain. So we do try to involve even young kids early on, just by even saying, hi, how are you doing? Do you know why you're here, etc. I agree with what Dr. Murguia Favela has said. Some of the practical things are, again, trying to encourage your son to answer questions at the physician's office. And sometimes as a parent, sometimes we feel like it's easier for us to kind of answer those questions, but to try to hold back and let your son, try to answer those questions first. As well, it's also helpful sometimes to, have a little note. I find most everyone these days has a cell phone or something. If you can have somewhere on your phone with the diagnosis, or your son's phone with the diagnosis, the medications that they're taking, as well as, any questions that may have come up in between visits, for your son to carry those, to be able to kind of answer those types of questions, I think is helpful too, in terms of, empowering him with the knowledge. And if you don't remember it, at least it's written down somewhere to be able to convey that and encourage that.
And just a quick addition to that, it also inquired, depending on where you live, there's an effort, the national effort, to create these transition clinics. And in some areas, there actually are formal transition clinics in BC. There's a transition clinic between this adolescent to adult. And I know here in Alberta, we have that effort too, to try to get it. And probably it's going to be something that is available throughout Canada as a way to particularly answer this question and to help teenagers move into more independent teenagers and then adults.
Thank you. A question from the audience. Can CVID turn into something else when the child grows up? Are they more prone to have certain diseases?
Yeah, we do know with common variable immunodeficiency, in addition to the risk of infections, that we can see some other complications that can occur. And as a child or a person becomes older, there may be a higher chance of developing some of these complications. And so some of those are autoimmunity. So again, sometimes you can have some low blood counts from autoimmune problems, or almost like autoimmunity in any other organ system, like inflammatory bowel disease, a Crohn's-like picture or celiac-like picture, thyroid disease, autoimmune skin issues, etc. And so these are things, again, that your physician or your immunologist will monitor when they see you regularly, just to ask if there are any new symptoms that you're noticing, and if there's anything that's concerning, they may want to do some more investigations or workup around that.
Fully agree.
Okay, thank you. I've got another question from the audience. When my child was diagnosed with ADA SCID, I was told that I couldn't breastfeed him because I am positive for cytomegalovirus. Mothers positive for CMV would be ever able to breastfeed a future child? Do we ever get rid of this virus in our bodies?
Great question. And I think that this leads to a lot of definitely fear for future pregnancies and all that. So yes to the first answer, second, no to the second answer. So then I'll explain. So first of all, yes, as you well point out, so when we have the high suspicion of a severe combined immune deficiency or of confirmed diagnosis of severe combined immune deficiency, we do check the CMV status of the mother to make sure that CMV is not present. If not present, we may allow to breastfeed. While we get those results, we may pause breastfeeding. But indeed, if CMV, cytomegalovirus, is present in the mother, we then, unfortunately, it's one of the hardest, I feel, discussions with these mothers is to stop the breastfeeding. And the reason why this is because CMV can be transmitted by breast milk, and any other baby, any healthy baby, any of us having transmission through the breast milk would not be an issue. But someone that has no immune system inside of them, this virus can go through and then actually infect the child, and beyond that cause manifestations of the infection. So to answer the first question, yes, if any future child does not have severe combined immune deficiency, there's no issue with breastfeeding, because the baby's immune system will be able to handle and suppress the virus. So then, about to get rid of this virus, so cytomegalovirus and other similar viruses like Epstein-Barr are very prevalent in our environment. So if we were to test the entire population, we would see that a high number of us are already exposed. We already have the virus and we don't even know. Viruses like this tend to go and hide in our genome, in our genes, and get into our DNA, and they just live there. And then whenever we are in trouble with some immune suppression, or we're like going through a transplant or that's important information to have, because these viruses can then all of a sudden show up. But in someone with SCID, they would be very dangerous to have a disease, an infection such as CMV or EVV. So to answer the second question is, unfortunately, no. To this day, we don't have any good way to fully get rid of this virus. But on the good side, usually our immune systems are very good at keeping them just to live cordially with us throughout life.
I agree. I have nothing to add to that.
Thank you. I've got another question. For children who have an aversion to needles, what kind of supports are available to help them get through their immunoglobulin infusions?
Yeah, that is, a challenge as well. I don't think I know too many people who like needles, but I have come across, some children who, and even adults, who can have a particularly difficult time with that. For us, again, we usually try to involve other specialists. So, for example, we have a child life specialist who can come, or even sometimes our social worker or our clinical nurse specialist who can come to try to do some work ahead of time with the child in terms of either distraction methods, calming methods in terms of like breathing exercises or focusing on other things when the needle goes in, as well as some potential therapies that could help in terms of reducing the pain, like some numbing creams or sprays could also be helpful too. In some really significant cases, sometimes we've needed to involve a psychiatrist or a psychologist just to help. Again, sometimes with these aversions, they become really, really significant in terms of really significantly affecting the ability to offer treatment. And in those cases, again, we may rely on additional mental health support to try to see, again, if we can come up with some other therapeutic strategies in order to be able to give the medication. Because unfortunately, for immune globulin replacement therapy, we need to give an injection, either through the IV or through the subcutaneous fat. So we do try to work with the child and with the families around trying to, make this as easy as we can for the child.
Yes, I would just expand that a little bit in terms of a few examples. For example, here in the hospital, we have child life specialists that truly go above and beyond and what Dr. Kim was saying, distraction and all that. So they have very different ways of, depending on the patient, to and how they respond to, from a simple iPad and to there's things like a Buzzy Bee that they run in the arm while they're putting the IV. They truly are magicians in terms of helping the kids to go through things. So I would ask if there's such a service like Dr. Kim was mentioning, and then if it goes beyond when it's truly affecting their mental health, even when they're not in the hospital. We know some kids that they're constantly anxious about just thinking ahead a month before that they're going to have a needle or they're going to have a lab work and so on. For example, here in the hospital, we have a needle phobia clinic. So again, what as Dr. Kim mentioned is mostly run by medical psychologists, the social worker, and to try and understand how deeply this issue is affecting the child's life, and it could be a very good big spectrum of that. So just ask around additional supports, just like Dr. Kim said. They may already be in place, and it's just a matter of saying, hey, you know what, this my kid is really struggling about this. Is there anything we can do about it? And I think that's all it takes, and usually there's all these services available.
Yeah. And sometimes, again, it's more scary at the beginning. And then again, as children get used to the treatment, some children become, really great pros and are like putting their arm out and like, here you go.
They even show the vein that it's like, oh, this is a good vein.
Yeah. So sometimes, again, it's, the level of support, I think, depends on the child and the situation and, again, how they do. But hopefully, again, as the supports are there and as time goes by, they kind of get used to it and then hopefully it becomes less scary.
Thank you. I needed to hear that as well. I'm not good with needles. Question from the audience. Should we have any restrictions such as no swimming pools, etc., for our 8-year-old who is getting monthly IVIG treatment to help her immune system?
So I think in that case, it also kind of depends on the reason why the IVIG established and the actual diagnosis of things. So and the reason I'm mentioning this is there's a few combined immune deficiencies in which swimming in pools may be risky for some of the protozoa, some of the organisms that may live within with swimming pools or lakes or rivers that may not be of problem to other normal patients or even other patients with primary immune deficiency, but for specific combined immune deficiencies, there may be additional risks of swimming in a pool, and they may be on immunoglobulin replacement for that. So again, this may be one of those questions that depends on immunoglobulin. Overall, someone that is on IVIG replacement, let's say because they don't make any antibodies for an X-linked gamma globulinemia, I wouldn't necessarily have that restriction of no swimming because they usually are quite healthy with the replacement therapy. They're like any other kid with as long as they keep getting the replacement therapy. But I would put the except of some diagnosis with the combined immune deficiencies where with particularly swimming in pools or freshwater like rivers or lakes could be a dangerous.
And also just assuming that they don't have a central line or a line that still is in place. Again, most of the times for IVIG replacement, it's a peripheral intravenous line that's put in and it's taken out at the end of the infusion. But sometimes, usually for other reasons, if a child has a central line for, again, other reasons, because we don't usually do that just for IVIG, you wouldn't want to get that line particularly wet or something as well. So that might be another consideration. But again, if it were really around antibody deficiency and they are receiving IVIG replacement, they don't have any other lines or tubes in place, I agree. I generally wouldn't make specific restrictions around swimming.
Thank you. I've got another one. What would you recommend to parents to bring along to their first meeting with an immunologist?
It's a really great question. I often suggest writing down questions that you might have ahead of time, because sometimes during the initial meeting, it might be quite overwhelming with lots of information. So if you have questions that have come up before the meeting, write them down. If you have any laboratory investigations or imaging that your child has had done, or again, medical records, because it's the first meeting with an immunologist, if you have any of those information, that would also be very helpful because again, in the initial meeting, we're often trying to find out as much as we can around your child, around any past illnesses and what's been done in the past. So having that information can be very helpful. And in addition, the immunization record is very helpful for us as well. And we do know that, again, depending on what province or even country your child grew up in, the immunization schedule can vary, it can be different. And so having a written confirmation of which vaccines and when your child has received is very helpful from our perspective, because sometimes the immune evaluation that we do to assess your child's immune system might involve checking to see if your child was able to make antibodies to the vaccines that they've received. And so knowing which vaccines as well as when they received it is really important in terms of interpretation of some of those things. And of course, you want to bring your child. Quite important as well as you may want to prompt or speak with your child about the appointment and see if they had any questions that they wanted to ask as well. In terms of, again, I always think it's really important to try to involve children in their appointments, hopefully to kind of even understand a little bit why they're coming in to see us, and engage them in being able to ask questions about their health as well.
Yeah, and I would add that it just and just a little bit of mental preparation of what type of questions you may get. One thing that we need to dig into is like the infectious history of your child. So we may ask kind of detailed questions about, sometimes in other clinics you may say, oh well, yeah, she's been having infections, but we would want to know more details about when and why and where, like eye infections, ear infections. So just be prepared that we will be digging into the infectious history. So if you can think about it beforehand, that will be very helpful to your doctor. We also ask a few weird questions in a way that an example would be, oh, when did the umbilical cord fell in your baby, right? Or did your kid had to be the teeth that had to be pulled out by the dentist? So a few of those details that you may not get asked by other physicians, you may be asked. So just be prepared for some of these things that you have to go back in your memory around your pregnancy, around the birth of the child, and all that we may want to dig a little bit further in. So just some preparation of just thinking of your child's history will be helpful. The other thing I would add is pictures can also be very helpful. Like if patients have had some certain things that we can see and are not present at the time of the, so nowadays with smartphones and all that, some of those pictures can be helpful. So I would say bring those two.
And sorry, one more thing is family history. So we often will ask if anyone in the family has had infections or problems with their immune system. And so sometimes this, again, may not come up very often when you're at the family gatherings and stuff, but maybe something to think about if you wanted to ask around ahead of time, if anyone has any known problems with their immune system or had lots of issues with infections, and what was done around that can often be helpful in terms of giving us additional clues for your child.
Awesome, thank you. Next question is, should we give our kiddo any supplements?
So this comes quite frequently in terms of like, is there something that can boost the immune system, or if there's something that we can do to really help out with the immune system. So the question is that it's not necessarily something that is so there's no good supplement or that to boost the immune system. I would say the best way to address immune health is having a healthy lifestyle, and I know that sounds cliche, but we do believe that it's just a healthy diet, trying to keep us as active as possible as long as the condition allows it, but having a well-balanced diet would not require you to have any additional supplements added to the diet, and that will be it. I mean, living in Canada, we know that vitamin D is vital, not just for it's just an overall good practice for not only our immune health but overall our health. So that will be one that in Canada will be a supplement that I think we all should get, is vitamin D. But beyond that, the rest would not necessarily be needed if there's a healthy, balanced diet.
I agree.
Hey, thank you. We've got another live one from the audience. Our teen has an undiagnosed primary immune deficiency that they have had since childhood, requiring sub-Q infusion weekly. Are there new developments, such as with gene therapy, to determine a diagnosis? And how important is it to have a diagnosis?
Yeah, so it's a very good question, and I think it depends on what sorts of investigations have been done in the past, as well as how recently were those investigations done. And it may be that there might be not a clear label for the immunodeficiency, but I think it's kind of in part of, what arms of the immune system do we think are involved based on the history as well as based on the investigations. And then in many cases, if the investigations don't point to a clear diagnosis, we often would consider doing some genetic testing, which can help to identify what the underlying condition is. We do know, though, that we still have a lot of patients where we know they have an immunodeficiency, but we don't know what the underlying gene is. And we do know that over time, again, there are new genes that are discovered or new developments that are made. So if genetic testing was done a number of years ago, it might be worth revisiting that to see again if they could either reanalyze that or if there's any additional genetic testing that might be worth considering. So these are things I think would be worth speaking with your child's immunologist around, is, you know, what the investigations were done so far, and if it's worth kind of either revisiting some of those investigations or revisiting genetic testing if it was done as well. Now, again, you don't need to have an underlying genetic diagnosis to be able to treat, right? Because again, we do focus on the child and how are they doing, what are the concerns, and what can we do around those concerns. And even in some patients with immunodeficiency, we've gone as far as even a bone marrow transplant without knowing the underlying genetic diagnosis, depending again on the severity of the immunodeficiency. So again, not having a clear gene or, you know, genetic diagnosis doesn't mean that we can't treat your child. At the end of the day, that's, you know, the most important thing is to focus on how your child is and what their symptoms are and what should or could be done about it. Again, depending on what other kind of functional or clinical testing has been done.
Excellent. Yeah, I would agree completely. I would just add, just to a little bit of context in terms of what Dr. Kim said. For example, if just 10 years ago, we would say that there were around 200 genetic causes of immune deficiencies, and now, as of last year, there are almost 500, right? So if, like Dr. Kim said, if your child was diagnosed with PI 10, even just 10 years ago or so, there may be new developments that may be able to diagnose genetically. As Dr. Kim said, maybe even then we know that we still have some that we don't. And then to the second part of your question is like how important is to diagnose. I would say that we always, as the immunologist, we always try to get to the diagnosis. Having a genetic diagnosis may help us know more about the actual condition and then what to expect for the future. Just like Dr. Kim was mentioning before around the autoimmunity part or some of the things that we may need to be looking after in the future, knowing about a specific gene that all other patients with primary immune deficiency share around the world, we may be able to better be prepared to that. So I would say that yes, as Dr. Kim said, to talk to your immunologist, because there may be ways to update that genetic testing, that if there was one, or if not, to actually do one, because yeah, there could be some relevance around knowing the genetic diagnosis, not only for your child, but also even just for the family and family members that may be important to know about their future as well. So.
Hey, thank you. I'm going to ask one of the submitted questions from earlier on. Okay. My child keeps getting sick with infections, but doesn't really get a fever and has normal blood work. I saw an online question and answer on TLRs, and I'm wondering whether this could be some sort of deficiency or malfunction. And if so, how would you test for it?
Yeah, very, very specific question. So I would tease it out a little bit, right? So one thing that again that I would probably ask you if you were in my office is like, let's try to talk about the infections first, right? What type of infections are you talking about? Some kids just by nature, some kids in daycares will have more viral infections than others, and we know that, and then they get to a point where they all grow it. So some kids are a little bit more sickly in terms of viral infection. So I wouldn't necessarily highlight that as an important. But if you tell me that these recurrent infections have been things like pneumonias or abscesses or things that had been requiring antibiotics, and yet the kid has not had any fevers or shown some sort of inflammation, then definitely that would raise a flag in our world to someone that their underlying primary problem is an inability to somehow within the problem, the primary immune deficiency, there's an inability to mount a good inflammatory response or a good response to whatever is causing the infection. And so we do have a number of these of primary immune deficiencies that we know that can be the case. But again, in TLRs, just to address that, is just one of them. I would say that is within our innate immunity, there will be a lot of different disorders, TLR deficiencies included, where the problem is an inability to mount inflammation. But again, I would go back to really teasing out what the inflammation, what the infections are, and whether these are more severe. And again, a conversation with your physician about your question may lead to more questions asked and teasing out whether going forward into testing something like that is needed. But more from I would take a step back and try to address it in a more general way.
I agree. It's really about the types of infections, how severe they were, and what sorts of treatments were needed, which would then, again, I think, inform how deep to go in terms of investigating the immune system. But there are, additional tests that could be done if, again, based on the infection history, we really suspected there was a problem, even if your child couldn't mount a fever. And oftentimes that may involve doing some genetic testing, because again, in some immune problems, the clinical tests that we have available may not be able to pick that up. There might sometimes be some research testing, depending again on the specific concern, but oftentimes we may want to go towards genetic testing. But I think, again, it really depends on the history of the infection. So this is, again, usually when you're immunologists, which really try to understand what types of infections, how many, where, what treatment was needed to help, again, decide on whether or not a part of the immune system might be not working well and contributing to that.
Thank you. From your perspective, how can we empower parents to speak up for their children and their conditions with their immunology team or other physicians?
I think that's a really great question. I think one is providing parents with information, right? So the more they kind of understand their child's condition, I think that helps them to feel more comfortable to be able to, speak up with other physicians. As parents, I always say, parents know their child best in terms of when their child is not feeling right or off or something. And so they are their child's best advocate. And so being able to, say that this isn't, how my child usually is, and it's for these reasons, and they have this immune deficiency that is called this, I think is really helpful to be able to say to other providers. And oftentimes, again, because immune deficiencies generally are a collection of rare conditions, you are more likely than not to come across providers who may not be very familiar with the condition. I feel like sometimes, again, having a sheet or a handout or a letter stating what the diagnosis is, as well as a little blurb, could also be helpful to provide to, the emergency department physician or, another physician who might not be as familiar, as well as the contact information for your child's immunologist. Again, we often will let our patients know that if they, need to go and see someone else who's not very familiar with their condition, they can always, reach out to us, and we'd be happy to provide some additional advice on the condition and whether or not that might impact the reason that child is seeing the other physician. But, empowerment through information, I think is really helpful, as well as I think, building relationships where people feel comfortable asking questions and speaking up for their child too. So we do hope again that your relationship with your physicians is such where you can say, you know, if you have concerns or if you have questions, you can freely bring them up and feel comfortable to say so.
Fully agree.
Thank you. I've got another one. How do you explain your diagnosis to a child? And could you give some examples of how you would talk to children of different ages?
Yeah, this is a very nice question because yeah, it definitely is. It does change with we see from newborns to teenagers, right? In our practice as an immunologist, and of course that changes how we approach the diagnosis and how we manage to explain it to the kid. And I think I mean there's different styles of how you do that. I do feel like kids, particularly young kids, are very like graphical. So there's some resources that I've known along the years where you can actually tell them about the cells, and they get very into it, right? Like knowing that you have fighters inside your body, and then this fighter may not be as good as working as well as it should in your body, and they really get it. Like children are very intelligent, and I think not only I think it's very important that we always include them into the discussion on diagnosis. Sometimes families are wary about, oh, maybe we shouldn't tell the patient because we don't want them to feel like different. But I think the more you explain the kid, the better they manage it, and they're very resilient in terms of how they manage their issues. And I think knowing and having their understanding at their level empowers them to continue engaging with you as a physician. So one thing I always do is trying to speak at their level, not just in terms of the language used, but actually physically at their level, and trying to be like kind of inclusive of their presence there, right? So it's important to one my nurses know that I have a rule when they come to my clinic is all the devices need to be turned off when I come in the room, because otherwise in this time and era, some of the kids may then during the entire discussion with the family may be on their device and not hear anything that was said or done, or I don't like that non-interaction part of it. So they know that I kind of made it a rule, and it's helped a lot because then I actually get to engage with the kid, and they hear what's happening and they know what's happening. And otherwise, yeah, they come to teenagers, and throughout these visits, they've never engaged with you, and that's not good.
Yeah. And sometimes we've also, again, for school-age kids, when they have to do science projects or something, we've, suggested that they do a project on their condition. It helps them to kind of understand their condition, but it also helps them with, educating their classmates or their teacher on their condition as well. And I've also seen that is really like empowering for the kids too, when they've been able to do a project and talk to their friends about what it is, but also, what they know. And I've seen like sometimes when they come back for a visit and you ask them, why are you here? And they give you this whole spiel that they've learned about their immune condition. I just find that really, really like inspiring and empowering as well to hear that too. So these are some, some practical things that we often would suggest, as well as, again, what Dr. Murguia mentioned is, continuing to try to engage children even from a young age, because sometimes even if they are on their device or, they don't look like they're paying attention, they're paying attention.
Sure.
And they're listening. And so if we don't address that, sometimes they may have questions that they may not ask, and then their imagination, in terms of trying to imagine what the answer might be, might even be worse than, having that conversation and trying to clarify some of these things as well.
Yes, I was just add the just ask your immunologist for other resources, because there's very nice graphical resources for kids and different ages.
Cartoon books and
cartoon books, YouTube videos, nowadays. So just ask.
And I think we've got time for one more of the submitted Q&As, and then maybe time for one more, Fiona, from you. Why do some individuals' Ig levels fluctuate between low, normal, and low? As a child gets older, does it continue to fluctuate, or is it an early sign of a possible immunodeficiency diagnosis later in life?
Yeah, so it might depend on, IgG or blood work levels in general are, when they take a group of children of varying ages and they do blood work and see the levels, and then they try to gather what the most common levels are to be able to come up with that normal range. But you're always going to have some kids on one end and some kids on the other end in terms of, being just outside that range. So it's either low or a little bit high. And we also know that IgG, which is a protein, can be lost if you have a condition where you're losing protein. So for example, in some people who have chronic diarrhea and they're losing protein through their gut, you can lose IgG as well. So it might not necessarily mean that your body isn't making enough, but you might be losing it for some reasons. And so again, there can be various reasons for having a low or low normal IgG. And so that is something to speak with your physician about. Usually, again, the immunologist will try to look for and make sure we're not missing other reasons for a low IgG, like medications, or again, a protein losing type of state, as well as assess how well it works. So again, in some people who have low IgG, they may be working very well. And so you may not need to intervene or provide any treatment. So in addition to the IgG levels, your physician will probably be also assessing how well they're working by the function. So are you making antibodies, for example, to the vaccines that you've received? There are some children, again, who have those levels, and then as they get older and those levels improve, which is great. But there are also some children who have low levels like that, and they may remain low, or they may become even lower, or start to lose the function. So this is where, again, your immunologist will follow just to see which way it goes, to decide if your child needs treatment, or again, if it's okay to watch, or even if it normalizes and we're pretty happy with that, we might not need to keep checking those levels.
And just one quick thing to add to all that, I agree fully, is that sometimes it's also important to look at the reference ranges, because reference ranges change very constantly along childhood, between reference ranges for the specific age group. And sometimes I've noticed, depending on the province, depending on whether there's community labs versus central labs, or was done even somewhere else, that sometimes the abnormal result is actually not abnormal, but it's because the reference range that was used in that particular lab was adult for adults, for example. And so it's something to, again, just talk to your immunologist to see that the actual reference ranges that particular lab used are good for your child's age group, and because sometimes it's actually not abnormal. It's just they do fluctuate, but it's because of age.
And thank you so much. I think that's all we've got time for in terms of questions today. But again, I just want to say a huge thank you, Dr. Kim and Dr. Murguia Favela, and Fiona, for I think we answered quite a broad range of different questions coming in, and we just had some thanks coming in from one of the participants. And just before everyone leaves, I just want to say that we have a Families and PI Community Connect group that runs monthly. That group's meeting on December 7th at 7 p.m. EST. And that's run by one of our volunteers called Emily Bell. So if anyone's interested in continuing the conversation, please join us for that one, or come along in January. And yeah, feel free to check out other events that will be coming up in 2024. If you have any other questions, you can always send it to info@communitycanada.org, and always follow us on social media. Again, thank you so much for joining us today, and enjoy the rest of your day.
Thank you, everyone.
Thank you for the invitation, and thank you for your questions.
Awesome. Thanks. See ya.